Awesome.
Okay, can you guys see that?
Yep, it's perfect.
Yep.
And it's, yeah, not on presenter view or anything. It's just your presentation. So it's perfect.
Awesome.
Shall I make an introduction?
Yeah, I think we should get started. It's 6:45 and we have a good quorum. And so I'll let Daniel Knott introduce our speaker today. Thank you for joining us on this kind of holiday week, Tessa.
Oh, it's a pleasure.
Thank you so much, Kim, and thank you, Galen. In particular, thank you on this pre-Christmas morning to Tessa Hadlock, the Director of Facial Plastic Surgery at the Massachusetts Eye and Ear Infirmary, one of the true global thought leaders on treatment of facial nerve injury and repair, who's really driven the field in tremendous direction during the course of her career over the last 20 years. So it's a particular pleasure to have Tessa join us to present today on her topic that's near and dear to her heart. So thank you so much.
All right, well, thank you so much. Should I just go ahead and launch right in?
Please.
Yes.
Okay, so I thought that today what we ought to do is not so much just give you like an overview of how we manage facial paralysis, but really to kind of talk, I think that all of us in academic otolaryngology have kind of matured to the point where we don't need to be talking about the basics of like workup or even how we longitudinally follow patients with facial paralysis, but we ought to start talking about kind of what the hot issues are and where it is that we are today and kind of like what the contemporary problems still are. And I really thought that would be something that kind of would be a little bit interesting and can kind of spark particularly the young people to start thinking about, well, like, okay, if I'm going to be somebody who is going to be taking care of these problems, where do I want to kind of put some energy? So this is really targeted a little bit for folks like that. And so just to really, really briefly recapitulate, over the past 25 years that I have been working on facial paralysis and facial reanimation, I feel like we have accomplished these three really nice things longitudinally and kind of systematically over that time. We have improved and refined and prolonged static suspension outcomes using fascia lata. So it's not like your daddy's fascia lata where there's a little piece that kind of pulls it up. It's a much more elegant thing. We use up to 6 ribbons of fascia lata. We've been able to do an awesome job with static reconstructions, way better than I think what we think about in like the 90s and the 2000s. The other thing that we have done is we've optimized reinnervation using trigeminal sources. So right when I was starting as an attending, the gracilis driven by the masseter branch of the trigeminal nerve had been described, but it wasn't really super popularized. And of course, a direct 5 to 7 nerve transfer was not even really described yet. That's something that became popular around 2012, 2013. Now, we didn't think of it and we didn't invent it, but one of the things that we did do was study it deeply and really systematically figure out kind of the best way to execute it. And I would say that the results from those bite-driven smiles, when done properly, have become like tremendous and really beautiful. So that's something I think about which we can be really proud. The other thing that I've spent so much of my professional career around is trying to improve free muscle transfer results. And what I mean by that is having them work more consistently. And when they work, actually having the patient like look good, because a lot of times you can get some movement, but it's still not aesthetic. So really bringing kind of like an aesthetic surgeon's eye to free muscle transfer with smaller and smaller slips and more appropriate vectors and avoiding bulk and all that kind of thing. So this is sort of like what we've done. But so just as a quick kind of demonstration of that, you can see that fascia lata reconstructions, I mean, even this that I showed you here is not even the very best of the best, but it's really much, much better than some of those just little cheese strings that we do. This is a great example of 5 to 7 transfer. This woman does not have a facial nerve on her right, and you can see how disfigured she is smiling. And then when she does a very gentle bite, she's able not only to activate all of her lip elevators, but also she gets that Duchenne phenomenon where the eye kind of narrows because we're sending axons a little bit to oculi and also to this entire upper lip complex. So really beautiful there. And just so you get a sense of kind of like the dynamic aspect of that, you can see that she can really learn the timing of this quite nicely. So that's sort of state of the art for static and for trigeminal trigeminally driven smiles. In the free flap cases, and this is kind of an older case at this point, but it does sort of show you that we're able to get, so this is driven by a cross-face nerve graft, so it's obviously kind of synchronous and it's a coy, but it's really a meaningful and beautiful smile. When she smiles, she can kind of tell her story. So that's kind of like the happy news. But like, what is the darker side? What is the underbelly of facial paralysis? Where do we need to be working? And this slide that I have written here is kind of like our naked truth. These are the problems that we have right now in facial reanimation. And problems there are. So if you think about reinnervation, we can have too much tone, like the 12-7 transfers that like shoot the kitchen sink into the facial muscles. You can get not enough tone, which the trigeminal inputs are guilty of. You can have vector problems when you do reinnervation, because if you have dead distal facial nerve branches, you may not be able to make the proper choice about which branch is going to lead to that favorable facial musculature. You can do really good educated guesses, but sometimes the vector is wrong. The other thing that can happen with a 5-7 nerve transfer is you can have a great result, and then it can almost like also over regenerate into the DAO complex and other things. So what was good can then kind of almost like turn bad, the same way that you might get synkinesis. Other problems with reinnervation, when we use the masseteric branch of 5, some people can get a lot of atrophy over the masseter and it doesn't look that good. And then obviously there's the involuntary prandial activation. When you're chewing, you can smile a little bit involuntarily. We did survey a huge number of folks who had this reconstruction. It does not seem to be a dominant problem. I want to say under 8%, or Suresh might be more familiar with the exact number of people who reported that as an issue, but it was not very high. Okay, with respect to free muscle, all kinds of problems. You can get too much bulk, the vector inset can be wrong, you can get superior displacement of the lower lip. With a smile, you can get inappropriate resting tone in either direction, like too much tone, where the upper lip is superior malpositioned, or you can have not enough resting tone where that oral commissure still sits too low. And of course, there's the problems of like poor neural penetration where the free flap doesn't move, even though you think it's alive. Problems involving static suspension revolve around poor midfacial stabilization, a lot of still filtral deviation to the healthy side with smiling. And it's hard to learn how to really inset properly some of these bands so that you really position things just right. Like one of the issues is that we do these under general anesthesia. When somebody's under general anesthesia, they don't have any facial tone. And so it's very hard to kind of predict how much tension you should put on that fascial band, because once you set it, it doesn't really shift a lot. So it's not like one of these things where it's like you overcorrect or there's any forgiveness. So if it's too tight in the nasolabial fold region, you're going to wind up needing to undo it and take it down a little bit. So these are sort of the problems that we've been wrestling with, I would say, in this decade. And my goal right now is to talk about kind of the little pieces of progress that we've started to make in this arena. So I'm going to start by talking about surgical innovations to get at some of those three things. And then I'm also going to address this issue of downgrading in the hypertonic face, the post-Bell's palsy, post-Ramsay-Hunt, post-temporal bone fracture, post-Lyme disease, where there was an incontinuity insult to the nerve and a lot of axonal misrouting and how we handle that. I don't think we'll have time today because this is a little bit of a shorter lecture to talk about future directions, but if anybody wants to find out more about that, of course, I'm always here to talk about that. Okay, so let's talk about the current innovations that we're working on. I would say that neural inputs are, how to improve kind of the operation when we're doing neurotization. So this is an example of a lady who had sacrifice of her facial nerve for a multiply recurrent acoustic. So she's at rest and with smile on the two left photographs. And then we did a 5-7 nerve transfer on her, and she has like an okay result. One of the reasons it's only okay is because she had already had a facial nerve insult with kind of poor recovery after a previous acoustic neuroma operation. So she wasn't starting from a normal excursion, but she really has a dramatically improved result that we know comes through the 5-7 because she has no spontaneous recovery. She had facial nerve sacrifice and no reconstruction. So, but the problem in people like this, as I mentioned before, is that the 5-7 transfer does not give any tone. So you can still see in the resting photo that she's got that widened palpebral fissure with a ton of scleral show, an inferiorly malpositioned oral commissure. And this is the issue that we wanted to start to chip away at. Another example of a guy who has a great result from a 5-7 transfer, but when you really look at him at rest, it does not do anything to help that tone situation. You guys can appreciate that, right? The kind of the flaccidity in that midface. So we think, well, where does tone come from? Well, God, 12 gives a ton of tone. So these two people both had 12-7s. The lady pictured on the left here had obviously a right-sided 12-7 transfer, a complete 12-7. This is a John Conley patient from the late 80s, early 90s. And you can see that there is just a lot of mass movement, a ton of hypertonicity. And the guy on the right is a Daryl Brackman patient who had the same issue on the left with a complete 12-7. And there's great resting tone. Both of these people look normal at rest. But when they go to make any kind of an expression, you can just see there's just so much going on. But it does kind of say to you, geez, is there a way to capitalize on like some of that tone? Are there ways that we can combine things? And that's when people are starting to now think about, oh, dual innervations and triple innervations and all that kind of lingo. So let me show you kind of our journey. So this guy had a 5-7, and I wanted to introduce tone. And this is before we took the hypoglossal facial as seriously as an option. So the first thing that we started to do was to put ribbons of fascia lata in at the same time as doing the 5-7. And what you can see is now this guy's resting photos, he does look much better at rest. And he retains that kind of nice smile. So the idea of introducing static support when you're doing the 5-7 is never wrong, and we do it all the time. There are plenty of patients out there who can't have their hypoglossal really touched because they have lower cranial nerve deficits from skull-base pathology and things like that. So, so this is a reasonable option. And over time, I think we've been able to make that work pretty well. So this is another example of a lady who has a nice smile from the 5-7, but we also put in a couple of ribbons of fascia lata, one to the nasal base, one to the nasolabial fold, and one to the oral commissure. And in addition to that, we put in some cross-face nerve grafts, 1 or 2 cross-face nerve grafts in her, one for the eye and one for the smile, because the contralateral facial nerve does provide some tonal input at rest. So if you look at her resting photos, you can see that she does have a better periocular situation, a better nasolabial fold situation, and a better resting oral commissure position. So, so the idea is that you can kind of correct this tone with static support, with cross-face nerve grafting, and also trying to introduce potentially some hypoglossal inputs. So this is another lady where great excursion from the 5-7, but at the same time, we want to try to introduce some cross-face nerve grafts to just correct a little bit the eye and the resting mouth position. So here it's pretty subtle, but I feel like her lower eyelid is just slightly covering more, a little bit less of that hint of almost like she's going to have some scleral show here. So this is just a sprinkling of tone, not probably as much as we would want, but occasionally you really get it. So this is a nice result from the 5-7 and cross-face nerve graft with direct hookups. Again, she's a little bit better and a little more stable in her mid face here, and she's just got a little bit less of this scleral show than she had here. These are very subtle things, but when people are articulating and speaking, they really can make a difference. Another example of a nice smile, but where her static position, especially around the eye, is better by this introduction of additional hookups. So the problem with doing cross-face nerve grafts with direct hookups is they're only appropriate to do pretty much immediately after facial nerve sacrifice. Because if you do them, if you wait 6 or 12 months or too long, the facial musculature will be unreceptive by the time a graft reaches all the way across the face. So this guy came to me, and the referring surgeon, I think in the Carolinas, or I can't remember, basically said, I went in there, I thought it was an acoustic, it was a facial schwannoma at the brainstem with compression. I took it out, and I was not able to do any repair of the proximal stump. So this is a great example of a person who is not going to recover spontaneously. So you don't feel badly cutting tons of branches of the facial nerve on his affected side. So he got a 5-7 with immediate cross-face nerve grafts. And I'm just going to show you his video. So he can smile. He's got this whole nice complex working with that 5 to 7. But the really cool thing is that he also has some really good activation of oculi from a direct hookup to the oculi branch and some spontaneity to that smile. So this is sort of the ideal scenario to do these kind of multiple contributions. But now we talked about 12 and what awesome tone that gives. But, when I first saw the results of the 12-7 transfer, I was like, look, we can do so much better with these kind of zonal reconstructions. Like, why are we going to screw around with this? But it's kind of experienced a renaissance, not to get people to smile, because it doesn't really do that. But it's experienced a renaissance because it provides the right kind of tonal input that may babysit some of these muscles so that you can drive them more selectively later, or just as a sprinkling of tone so they don't wind up with that sequelae of flaccidity. So we first started doing this. I first started doing this kind of with a colleague, and you can see a great result from the 5 to 7. And we introduced a very minor 12 to 7 component. And I would argue that despite the fact that we took down her tarsorrhaphes, so that's a little confounding, I would say she has no improvement really in the tone of her face. And that's kind of how minor this was. Again, when you really come at it from the perspective of like, I do not want to hurt somebody, and you only cut into that hypoglossal just a little bit, you can see that that can lead to kind of an underwhelming result. But as time goes on, you can get a little bit more bold about these things. So we do these 5-7s and 12-7s simultaneously. The smile is good and just a little bit more tone. So now you can see a little crease at the oral commissure. The oral commissure is not sinking downward the way it is preoperatively. It's a more neutral, still not great, but better. And then as we gain experience with it, you gain a little bit more comfort with it. Here we've got the nice smile from the 5 to 7, and then that hypoglossal corrects the oral commissure position just a little bit more and brings up that lower eyelid. So we're looking for very specific things from the hypoglossal. And we ran the whole gamut, like we did not enough, and then we kind of did just right, and then we were introducing a little bit too much trigeminal input, which I think is kind of shown here, where the smile is good, but there's just like a lot kind of going on at that eye. And if you look at rest, I would argue that he's no longer in that flaccid position, but actually he's like a little bit overcorrected at rest from the tonal input. So I'm only showing this so that you guys understand it's like a touchy switch. It's like a touchy switch. It's not really obvious how to do this. Now, if you have too much tone, it's easier to knock it back. And if you don't have enough tone, there's no way to kind of augment that. So just a quick visual on what it looks like. We find the main trunk of the facial nerve. We bring it all the way down to the hypoglossal. I now have tended to do these with an otology colleague with an extended mastoid drill out, where they'll get the facial almost at the geniculate, and then it just flops right onto that vertical segment of the hypoglossal nerve, and we're able to do really quite nice neurorrhaphies. I think Suresh joined me for the first 1 or 2 of those. But so here is the 5 to 7, and here is the 12-7 with just a 40% neurotomy into that hypoglossal and a nice neurorrhaphy. You can also combine like free tissue with 12-7. This is an example of a lady we did a 12-7 on. She got really nice tone, but no meaningful smile. We layered a small gracilis onto that. And then we were able to give her both that nice smile with a trigeminally driven gracilis, but also resting tone that looks good. So there's all kinds of combinations. And I think the take home message with this is just that you want to keep on combining neural inputs and static adjuncts until patients really look perfect. This lady, I think, is really one of our very best results. She has a trigeminally driven smile, but it's from the deep temporal nerve, which actually does deliver tone, unlike the masseteric branch. And I think that despite having no proximal facial nerve, she really almost looks normal. Like she could sort of fool you on the street kind of thing. Okay, let's switch briefly now to muscle inset modifications. We talked about muscle, some of the vector issues and the fact that we get some lower lip malposition if this is inset incorrectly. So we have been working over the years to modify muscle insets to be nicer. I showed you this girl's case earlier, and I'm sure you noticed, but she really has that very much I have her closing her lips here. One of the reasons that I have her do that is to camouflage any lower lip asymmetry. But it turns out that when you have people do an open lip smile, you can often get a situation like this, where on the healthy side, they have this lower lip displacement, but they have such superior malposition of their lower lip on the affected side that it really doesn't look good. So they themselves kind of learn to do a closed mouth smile. This is a problem that I really didn't recognize for many years until a junior colleague kind of came along and said, why is the lower lip always looking bad? And I was like, geez, well, it doesn't always look bad, but it does sometimes look bad. And so that's sort of what prompted us to do a little bit more digging. And again, this is one of the problems, is that this guy had had a gracilis many years ago by me, a dually innervated gracilis with a single vector inset. And you can see that his smile doesn't really show that weird lower lip asymmetry. In other words, it doesn't always come up. And so when a problem doesn't consistently come up, it's a bit harder to recognize it. Nonetheless, when I finally did accept that this was somewhat of an issue, we started working on repositioning the inset of the gracilis muscle to the medialis. So instead of putting it out where it might really pull up the lower lip, we started insetting it much more across the entire superior hemilip, much more like this, like where, so the sutures go sort of where these X's are, rather than around the whole bend here. So you can see it here in this photograph. And I feel like this lady shows it best. This is a lady with our newer inset. And you can really see that that vector is much more sort of superolateral without screwing around with the lower lip. Now, we have dabbled in this concept of multiple muscle slips for the multi-vector smile, things like this, to kind of replace the whole complex. But this is a dicey business too. Number one, we can't really predict where the axons that are coming in from this obturator nerve are actually, whether they're going to dominantly go to this pedicle or that pedicle of muscle. And so you can kind of, I remember talking to Patrick Byrne once, and he sort of said, oh, I did that, and all the input went to like the vertical thing. So the person got a great snarl, but no smile. Also, I really feel like the way that we've been insetting the muscle across the upper lip, we've sort of taken care of the correct vector without having to do this. So I show this to you, not to tell you that I'm doing it, but to say that we have done it, and I haven't seen it be really superior to more traditional methods. This is another example of an operation that we did do just only a handful of times, and I believe that my former colleague may be also continuing to do this, but this is the idea of trying to deliver both superior smile and also some lower lip displacement. But again, a very kind of a complex, it like looks pretty in the pictures, and here's a woman who had it, and you can see that she's got a nice superior smile, and her lower lip is more balanced, but I would argue that the lower, she has Botox in this contralateral lip, so that makes it look a lot better. And and because her superior lip is pulled into the right position, I really can't be 100% sure that the lower lip is truly in a better position. And certainly this is a trigeminally driven free flap. The only way to drive both paddles is by biting down. Now, when we show our lower lip display, we really do that when we're like, when we're doing like a spontaneous laugh. So a trigeminally driven smile is de facto not spontaneous. So it's possible that kind of trying to introduce that in this particular operation wouldn't make the most sense with the kind of human mimicry that we like to do. Nevertheless, I have seen these move a little bit. Here's an example of a lady who had it, and when she bites down, she gets both a smile and there's a couple of millimeters of movement in her lower lip. I still would argue that most of her correction is from the fact that we treat her contralateral lower lip with Botox, but nevertheless, it kind of tells a nice little story. The problem with doing too much in the lower lip is right here. If you artificially displace the superiorly malpositioned lower lip too far down, you have a massive functional problem with somebody. So this is a lady that I met when I had just seen Julia Terzis talk about lower lip reanimation with the digastric transfer. And I was like, ooh, like I can't wait to go do this. And this was my third one that I did. And I was so proud of myself. And what I actually did for this lady who had this isolated lower lip weakness was I functionally devastated her by doing a digastric transfer that then foreshortened a little bit. And she developed oral incompetence, a speech impediment, and a lot of other problems, and really could not stand. I mean, I ultimately took that digastric transfer out, but even when you do that, it's pretty difficult to reverse some of the scarring that happens in there. So really beware of screwing around too much with the lower lip. It can lead to devastating functional problems. And this is an example of that same thing. This lady came to me after she had had some kind of, she was a frozen face from like a Bell's palsy or something like that, a pregnancy-assisted Bell's or Ramsay-Hunt, which now we would treat with all kinds of like downgrading procedures. But instead, she had had a T-flap, a temporalis muscle transposition, and a platysma transfer to her lower lip. So the photograph that you see on the left is her at rest. So can everybody appreciate how her upper lip is like superiorly malpositioned and her lower lip is inferiorly malpositioned? And this leads to both the speech and articulation problems and oral incompetence with liquids and solids and stuff. This is a devastating problem. Now, I set out to kind of undo this. So we placed a cross-face nerve graft, and then we went in to do a gracilis for smile, etc. And I undid everything that I could, and she still has only wound up in the photograph on the right. So what you can appreciate is that, yes, she's better, but she is not all the way better. And I'm not sure that she can get there. Once you mess this up, I think it's very, very difficult to correct. All right. A couple of little innovations with static suspension, as I mentioned, we sort of call this like enhanced static suspension. We now tend to use 4 ribbons of fascia lata, 1 wide band that goes to kind of the superior aspect of the nasolabial fold, 1 that goes to the oral commissure, and then can everybody appreciate this very horizontal band right here? That one is to stabilize the philtrum. So it's very horizontal and it's designed to keep the philtrum from pulling over to the healthy side. And then of course, the band up here that I show is the nasal valve correction. So this is sewn to the sesamoid cartilages right here at the ala. So this has really, so these are the kinds of examples of what we don't really need to be doing anymore. These are all examples of people who came to me kind of like with quote static suspension. And you can see like this guy's got a fistula from a piece of Gore-Tex. This lady has no nasolabial fold at all. This guy, again, philtrum shifts way over to the healthy side and no real correction of the nasal base, etc. I mean, these are just not, I show this slide because this is like not what you want. And instead, what you want is to take people like this, and with combinations of static suspension, you want them to start to approach this. And even this is before we really started insetting that nasal valve, the nasolabial fold up to the correct position. So you really want to start getting things that look almost normal at rest. Now, I mentioned the philtral stabilization problem. We started to notice that even our static suspensions that look good at rest, you still had a lot of this philtral pull to the healthy side. So we set about kind of figuring out how to stabilize it. So first I would take like a big band of fascia lata and I would try to do the nasal base and the philtral pillar and then nasolabial fold and yada, yada. I realized that if you don't have really independent control over each of those anatomical landmarks, you really can't do it. So now we're more kind of moving to this picture that you see on the right, where we can put a piece of fascia lata in the lower lid to suspend it. We have the nasal valve, the nasolabial fold, the oral commissure, and of course, this ever horizontal philtral stabilization band. You can even introduce a band into the lower lip to keep it from getting pulled into the wrong position when the healthy side moves. So I would say that much more contemporary results from the elegant static reconstructions look like this. And honestly, if you really look at the data in terms of like disfigurement, 70% of the disfigurement is in the static position. So if you can do this to a patient, you don't even need to screw around with some of the dynamic reconstructions. Of course, it's nice for people to be able to smile, but I'm just saying. Okay, so philtral stability, we did look at a bunch before and after we did the philtral stabilization band, and you can sort of see that this girl does not have the facial stabilization, the philtral stabilization band, and this girl does, but they have identical reconstructions outside of that, and you can see that her philtrum is much more appropriately positioned. I won't talk about this. I do want to take just a moment on downgrading because I think I only have 10 more minutes before I take questions, but downgrading has kind of been an area around which there's been tremendous interest because the opportunity to treat people is out there. People who have had the most common causes of facial paralysis sort of are in need of downgrading of their hypertonic and synkinetic musculature. So there are really kind of 3 ways to downgrade. You can take away muscle on the affected side. You can take away nerve branches that lead to that muscle on the affected side. And you can also neurectomize, myomectomize, or chemodenervate function on the good side to introduce better balance. And so combinations of all of these things is really what you want to be doing. I initially started with neurectomy by doing highly selective periocular neurectomy, where I would bring a whole bunch of periocular branches through the skin, and I would then wake the patient up and snip them each individually, so that I could kind of titrate how much periocular function I was taking away and not take away too much. And the initial results were very promising. The pre-op is all on the top panel, and the corresponding post-op is on the bottom panel. And you can see that it's an extremely immediate correction. But unfortunately, all of these patients wound up developing Botox requirements again down the line. Now, they went from uncontrolled with Botox to controlled with Botox, but still it wasn't a permanent fix. But then Babek Azizadeh came out with this kind of revolutionary paper. I want to say it was 2018 or 2019, where he was showing this kind of a smile improvement by neurectomizing not the periocular branches, but actually some of the midfacial branches. And so this was very, very captivating. And in fact, people got so enthusiastic about this that they didn't necessarily read all the fine print in the paper, which I am providing for your own edification. Over half of these patients had a facelift. Only 26 of these patients had only this procedure. In other words, there were lots of adjunctive procedures that went into results like this. So this lady, yes, she is pre and post the selective neurectomy, but she also had a platysma myotomy, bilateral facelift, upper blephs, fat grafting, and CO2 laser. So a lot of things go into making somebody look better. And we as surgeons don't always look at the details of that. Instead, as surgeons, we're like lemmings running off a cliff, like we can't wait to do this operation. And that's where you can get into a lot of problems, because there is an underbelly of this highly selective neurectomy. So I'm going to show you the underbelly. This is my first case. I did this with like Babek on the phone. From my OR, I was like, Babek, I've got these, kind of guiding me through it. And what happened with this lady was that she was someone I took care of for many, many years with chronic Bell's palsy, a frozen face, the classic downsloping of the upper lip. When she smiles here, she functionally has no movement of the oral commissure here. And I opened up her face. I stimulated the branches, which I'll show you on the next slide. And the lady wakes up with this like amazing difference in her smile, like truly amazing difference. I had been taking care of her for 15 years. I never saw her upper dentition. I never saw the oral commissure go upward. I'm like, wow, this is easy. It must always be like this. And Babek said on the phone, he goes, Tessa, it's not always like that. Like, beware of that awesome result. And he was absolutely right. So just to show you how the operation works, I don't know if you can hear my audio, but I keep that branch to the DLI because I like that lip depression. I take all that mentalis branch and DAO, take that mentalis and DAO, they go. I take all that negative stuff. I take that buccinator branch, but then I keep this branch. Keep anything that has nice upper lip movement, I keep. So what you can see is these are the 5 massive facial nerve branches I chopped out of that lady. This is her case. So I saved a couple north and I saved 1 south, but I took away 5 massive midfacial branches. And she got what I would consider really a beautiful smile. Here's another example of a really nice result from that. The problem that I'm not showing on the slide is that first lady developed oral incompetence. She can smile, but she can't get the tightness of the orbicularis oris because it's an area that I denervated perhaps a bit too much. It's resolved now with a little bit of filler in the lower lip, but it's a little bit of a rough go. This is another example of a lady. I was so proud of this result. Her narrowed palpebral fissure width is corrected. Her oral commissure is moving. It's beautiful. But I followed her out a year, and ultimately she wound up regressing to the same spot she is now. So there's a lot of pieces to this that we're trying to really figure out right now. And unless you treat it academically, it's very hard to get at those answers. But I'm just showing you here what the maps usually look like. The red are the branches that we take, and the blue ones are the ones that we preserve. So usually we take a significant periocular branch, then we preserve everything kind of in this zone that's right around the zygomatic arch and just below it. And then we take out a whole series of branches from here all the way to the mandible, to the lower border of the mandible. And then usually there's a very pleasing lower lip depression branch further down that we save. So this is a very characteristic kind of pattern. And again, this is another example. And what I love about this is it shows that if you can drop the resting position of the lower lip, you get a huge benefit, a huge balance in that smile. And that's where I actually learned from doing these operations that I think that all of that hypertonicity that goes to the mentalis, everybody, especially the residents, should know that the mentalis is a lip elevator, whereas all the other lower lip muscles are depressors. So I think there's a lot of mentalis tone that causes that to shoot up too much. When you denervate the mentalis, you get that much more dropped position of the lower lip. So, a mixed bag. And I think that, even though we show beautiful corrections in some of the emotrix parameters and in the quality of life parameters, and we see this improvement in smile when we ask people about how they're doing, and we see that they look better objectively to us, we can't discount some of the functional problems that we introduce when we do this. So this guy, again, I consider this was a guy I took care of for 20 years. He never smiled. I did the denervation and he got what's a beautiful smile correction. But he developed oral incompetence, and you can see here he is puckering before and puckering after, and you can appreciate that lack of ability to really pucker and a little bit of atrophy of the upper and lower lip. This gives him a lisp, a little speech impediment. This guy's a recovering alcoholic. It's very important to him that he never sound impaired, and yet he sounds a little impaired because a little bit of air kind of escapes through that side. So, I think my message to the trainees particularly is if it kind of seems too good to be true, like it can be. Other lessons I've learned are that aggressive resection can evoke minimal objective change to me, even though people subjectively can feel better. And then this is that result I showed you, pre, post, and then long-term. And look at her long-term ocular synkinesis is practically worse. And even though her smile hasn't reverted completely, it's well on its way. So you got to really be respectful of the fact that a lot of these things are a journey. One brief word on myomectomy. We've got really 5 great targets for myomectomy. The DAO, which I commonly take out in the office, the buccinator, which is on that inner surface right under the pink mucosa in the cheek, the platysma, the mentalis is pretty easy to resect in the office, and then of course oculi, where we tend to resect a big pie-shaped segment out laterally. I don't want to go through this in too much detail, but here you can see hypertonicity in the DAO, and that gets really nicely corrected with removal of that muscle. There's a video that you can find on our website, facialnervecenter.org, that kind of shows how to do that. But the data are pretty compelling about DAO. Here are emotrix. Emotrix is just a quantitative program that gives you really objective measures of how much you're improving things. But you can see the symmetry indices really jump quite a bit after. And when we ask people the quality of life question about oral commissure excursion, we see a statistically significant jump. So buccinator weakening, some people do it with Botox. I tend to do it more surgically because Botox can also be unpredictable in the buccinator. But this is one of my colleagues' results where I feel like the chemodenervation of the buccinator did very nice things. We do a ton of lower lip asymmetry management by contralateral weakening. We also resect the DLI on the healthy side in the office. And there's a video, again, facialnervecenter.org, where you can watch that. This is an example of platysmectomy. We used to do it a lot in the office just by exposing like a whole 1 centimeter strip of the muscle. We started by doing it through a single incision, then we started doing it through 2 little incisions, and we create a tunnel. But now when I really want to exonerate the platysma, I tend to take people to the operating room, and I do it in conjunction with the denervation. This is an example of office-based mentalis resection for a lady who had terrible mentalis dimpling. I just made a little submental crease incision. Here's the mentalis. I resected it. I also harvested a little piece of true temporalis fascia just from the temple, and then I inlaid that fascia right in there to create like an additional mechanical barrier. And you can see that for her terrible mentalis dimpling at the beginning, it's really smoothed out quite a bit. And here's another example of that dimpling and how it disappears once you do that mentalis resection. These are examples of oculi myomectomy that we do in conjunction with denervation. And so I literally cut all the way down to bone, right by the eye here, right by the orbit. with like a needle tip Bovie. I take a big, just a crescent shaped wedge of that muscle all the way out. And in order not to have a little contour defect from the skin flap, I harvest a little kind of a dermal graft. And this yellow thing is the dermal graft, a little fat on it. I'll pop it right into that area so that she doesn't have a divot right there. So pretty much that is what I wanted to cover. Oops, I don't know what just happened, but I think as far as future directions, future directions I think are really going to be wearables and implantables that will drive the paralyzed side from the healthy side. And I think that I think you're going to see a lot of advances in that in the coming years. And the other thing that I think that we're very slowly at an iceberg's pace doing is we're moving towards more standardized outcomes measures. And so I think that with facial recognition and kind of the popularization of some of these ways of doing things, I think that we're going to find more widespread adoption of the program Emotrix that we have developed and programs that are even better than what we've developed. So that's sort of where I wanted to leave it. So I think that leaves us a couple minutes for questions.
Thank you so much, Dr. Hadlock. That was really inspiring. Does anybody have any questions? Feel free to raise your hand or chime in.
So Tessa, I've long admired the way that you are able to bring an academic mindset to this and study things. At the same time, drive innovation forward in a meaningful way. Could you just briefly discuss how you manage innovation in patients where perhaps innovation might lead to some negative outcomes and how you handle that? Because if anybody's doing this in a systematic way where they're actually being thoughtful, rigorous, and reporting it, it's you.
So I am so happy you asked that question, Dan. And I am, this is a subject that is extremely near and dear to my heart. This idea about responsible innovation is a really, really tricky one in surgery. Because if we, I kind of came of age research-wise before almost like IRBs. And, it was more like just like stacks of charts and you look through them all and all that. And then all that changed with HIPAA in 2008 and rules and getting permissions and data repositories. And all of a sudden doing clinical research and trying to develop insights around things became like almost impossible. So I would hate to see that surgical innovations would get that kind of restriction because it is so inhibitory to the encouragement of breakthroughs. And of course, the first time Babek Azizadeh did a selective denervation of the midface, it was a risk. And we all take these risks. The problem is that unless you are extraordinarily dutiful to that risk that you took, you're harming human beings. So I was a beginner once, and I had only done 2 gracilis flaps in my fellowship. And for the US and an ENT program, that was a ton. And so when I started doing gracilis, my first few outcomes, there was movement, but it wasn't really that aesthetic. For me to be responsible about that, I went up to Canada. I saw Ralph Mankelo do it. I learned after I had already tried it and messed it up a few times. So I wasn't like a naive observer. I was already somebody with like skin in the game. So I think one way to stay away from being irresponsible is to really make sure that you appreciate the wisdom of the senior folks. The second thing is that it's okay to have a bad outcome if on the back of that bad outcome, you're going to then have hundreds of good outcomes. I think that what we tend to do, what I see the younger generation doing is they might be so wedded to like, I'm an innovator. I'm dying to innovate. And what they do is they innovate a few things that don't work. They bury those instead of announcing, hey guys, don't do this because I already did it and messed it up. They hide it because they're so concerned about how they look. Okay. And then they go off and innovate some other terrible idea and hurt another population. And then they sweep that under the rug. And this is a cycle that's happening kind of like everywhere. It happens in private practice, and it happens in academic settings, and it happens in my center. And that is not what we want to be doing. We have to be, it's almost like the way to avoid that, or the way to do responsible innovation, is to make sure that you're not working in isolation, and that you've got people who can tell you when, you know, you want to be receptive to saying, I'm going to try these, but I want somebody else to almost like look at my outcome, because you see that an outcome doesn't lie. But right now our climate is very siloed, and it pains me deeply. And I fear for innovations in facial paralysis, because I don't think that my approach is an approach that is really embraced even by the big names in facial paralysis. That's what
I think that's why this lure of selected innervation is so powerful, because it's easy to find facial nerve branches, it's easy to cut them, and the patients are out there in droves that have frozen faces and post-paralytic facial palsies. So there's this, anybody can do it, and I think that's one of the big dangers of that operation, is that
I couldn't agree with you more. Yeah. It's a dicey thing. And I'm here to tell you that I did 60, and then I looked at those 60 patients over and over. I've got a PowerPoint of all 60 people with pre-op smile, post-op smile, long-term result, quality of life, blah, blah, blah. And the only thing I can say is I am trying to put that into the literature to try and get us to backpedal a little bit. I think the operation has a place. It's just that the proper counseling of patients is critical. And then I think, Dan, the other thing that is so important, especially for the trainees to recognize, is that facial plastic and reconstructive surgery is really weird, because we compete a lot with people in the private sector, and those are people who are operating like for cash. And so when there's a financial motivation for something, you can have such an unconscious bias where you're like, no, I'm really doing it like to help the person, when actually it's kind of helping, like, you know, your financial situation. So, I mean, it's just a very difficult conflict of interest sort of thing to separate. Now, I'm not saying that I think there's a lot of great care being delivered, and I think that the folks who have innovated in this space are good doctors and are helping human beings. But I'm saying that as a young trainee, or as a person who's a very occasional operator, you have to be really aware of these pitfalls, and you have to look inward, and you have to say to yourself, as part of your Hippocratic oath, that you are not going to harm people, and that even if you harm somebody a little, if you need to be making up for that like the rest of your career by taking the data that you learned from that mistake and integrating it into the way you think, like for the rest of your life, basically.
Absolutely. Yep.
I guess I'll get off the soapbox now. People are like, this lady is screaming at me. I'm sorry.
Thank you.
I think that we might have a couple more questions, but we are at time. So I just want to take a pause and let people who need to go to their clinical duties go. And officially thank you when there's still some people here, and say happy holidays to everybody who needs to drop off. But Tessa, if you're available to stick around for a little bit, there might be some more questions.